but there's also just a lot of choices. So as we move through this, and even after this, I'm still working on pulling together some information I got from that class that was beneficial to me that I will get out to you. Okay, so today, a goal would be that we start a process to provide high quality wound care based on best practice to all of our patients. Goals to be confident in our wound assessment and creating plans of cares for our patient, understanding wound management principles, and establishing wound management goals. Knowing when to refer to home health or something like that, and ultimately working toward a standardized protocol for wound care at volunteer hospice. Wound management, was anybody able to open that form I sent them or no? To follow along?
Yes, I got it. I have it open.
All right, because it has a lot of information on there. I'm going to kind of scan over, but you do have this in that information sheet I sent you. But when we're talking about wound management goals, we're talking about maintenance, preventing infection and deterioration. As hospice nurses, our wound care shifts towards the palliative ambition, which Elizabeth used that word and I loved it, even though she didn't remember using it. But I like the term palliative ambition, right? Because we have to remember when we're talking about hospice, comfort, long wearing, pain-free, odor-free, easy to use, inexpensive, right? And I have found since starting here so often, if somebody had a wound, it was refer to home health, refer to home health, refer to home health, which, as we all know, in this challenging time of COVID and lack of nursing and lack of medical, all those things, you know, when you're talking about somebody having just a few months to live and then we're referring to home health, like it's just not the best thing for our patients, I feel like. So if we could get away from that. And then wound management. So those are goals, wound management principles, controlling and eliminating causative factors, providing systemic support to reduce existing or potential cofactors, and maintaining a physiologic local wound environment, meaning, you know, the principles are just to keep it locked in and not let it get worse and hopefully keep them comfortable. Phases of wound healing. For some reason, this was kind of new to me. Have you guys like heard of phases of wound healing? Like, is that familiar to you, Anne or Jen? No, me either. It's so weird. I mean, it was kind of familiar, but so there's 3 phases, 4 phases of wound healing, and we're going to go through each one here. So we start, and on that handout I sent you guys, it has like what you see in the beginning. We have hemostasis, an inflammatory phase, which kind of go together, a proliferative phase, a remodeling maturation phase. So this is kind of those phases that you see, you know, acute, progressing. And it's what is really occurring underneath. So you have the wound, it shows hemostasis, inflammation stage here, where there's the actual wound happening. You have neutrophils moving in, damage, you know, the body's going low. Proliferative phase, and we're going to get more into these, and then to the remodeling phase where collagen is moving in and closing it up. So this is extremely appetizing at 8:30 in the morning. You know, y'all want to see that. So this is what we're going to talk about right now, the inflammatory phase. So again, kind of the same thing. It starts with hemostasis. On a handout I says is essential to life. Vasoconstriction happens, platelet activation and aggregation, thromboplastin makes a clot covers, but you can see all the nasty little bacteria is moving in and everything happening there. You see the inflammatory phase to the right, everything happening in there. Proliferative phase, that's where we're moving into, and that inflammatory phase is about, you know, from immediate injury 2 to 6 days, moving into the proliferative phase, 2 days up to 3 weeks. This is when all kinds of things are happening in there. You got the macrophages, platelets, neutrophils are still hanging around. Some, you know, they're getting rid of bacteria. All this stuff is happening. And during this granulation, tissue is being built, fibroblasts laying collagen, filling the defect, causing contraction, pulling the wound, attempting to start pulling the wound together. Epithelialization, epithelial cells are growing and spreading, and you know, capillaries. There's so much happening here. It's a lot. Remodeling phase. This looks excellent, right? If we could get all our wounds to look just like that. Restoration, remodeling, maturation, 3 weeks up to 2 years to happen, depending on the wound. A new collagen forms, which increases the tensile strength of wounds, right? So that it prevents it from ripping open is a goal. Scar tissue is only 80% as strong as original tissue. I think that's important to remember, but again, you can kind of get a visual of that here. Other characteristics just talks about the phases there. You can see they're overlapping, right? You can move forward or backward through the phase. It can get better, then suddenly it's getting worse, and then it becomes stagnant. Quite often it'll be stagnant in the inflammation stage. I think we've all seen that, right? Like that acute injury phase, and it's just not getting better, and that's when we have to stop and question why. Why are we pausing in that phase? So for me, this was important, something I really learned. So I highlighted it in bright yellow for all of you. Assessment first. So always, right? Always, always, always assess the patient, assess the wound. And these are kind of simple steps to me. It just makes it easier. Decide on the wound type, which we're going to talk about. Set goals, select approach to begin treatment, and understand that the wound needs change as time progresses. So to me, that just kind of sucked it all together, and it's always assessments. And of course, history, right? Like, as we all know, you walk into the house, and from the moment you're with a patient, this history is floating around you. It's not like something you're stopping and taking notes on. Our admission nurses do excellent getting histories, and families know so much more, sometimes more than we want to hear. And it just pours on you as you're doing your assessment. So really important, because a lot of that stuff like functional ability, incontinence, nutritional status, all those things obviously with hospice are part of the problem. Wound assessment and documentation. Just again, some simple things that were helpful to me is describe what you see using terms that you know, right? Like, you don't need to get all fancy. If you don't understand a term, don't use it, because why, right? Like, it doesn't make sense to you. It probably won't make sense to anybody else. So describe what you're seeing: anatomic location, size, shape, classification, base, edges, margins, exudate, infection, peri-wound, skin, pain. So those are all things that we're going to address in this class and next class to kind of help pull that together. And in that assessment of skin, also just skin failure is an element in which skin and underlying tissue die due to hyperperfusion that occurs concurrent with severe dysfunction or failure of other organs. And for me, that was like, ding, that's like every hospice patient we have, right? Like, everything fails. And so yeah, we have to, when we talk about why did it fail, be a detective, ask questions, avoid assumptions, and again, describe it in terms that you know. So this is touching base on assessment. So again, a picture is worth 1,000 words. We got to decide if we're going to do pictures and upload them into our EHR. We want to measure it if possible. Use cellophane tracing. We got these awesome little chopsticks to stick in the wound for fun. No, I'm just kidding. It's gross. To measure. I really like the concept of describe the shape, right? Simple. Is it round? Is it oval? Is it butterfly shape? Irregular edges? Square? I seriously just can't stress enough how this class helped me realize just describe what I see is really beneficial. Location, anatomical location, right? Describing, is it on the elbow, medial, lateral, posterior, anterior, all the descriptive terms we know to really describe where that one is. Using, when we're talking about size, we use centimeters. Measure, head to toe is your length. Width is 90 degrees perpendicular to that, side to side, and every measurement should be done that way. Yup. And so, and looking at the dressing, right? Walking in and seeing what dressing is there and taking note of that. What is the drainage? All the things that we kind of do anyways. The base, this was a kind of newish thing to me in a way. Is it viable or non-viable? Looking at the wound base, and Elizabeth is going to go over lots of pictures with us about the, like, is it viable or non-viable? Meaning non-viable, it has dead tissue on it, like this picture here with you know, is it eschar? Is it necrotic? What is it? It's dead. Or is it nice and pink and healthy looking and ready to start that granulation process, growing up epithelialization and those things. I also like this, describe it as a pie, right? Super simple, cut it in 4. 20% of the wound is eschar, right? 20% granulation tissue, but you just use that approximately 20, 50, 75, 100. I think that makes it pretty simple. And again, a lot of this stuff is like the best practice I was learning in the UW course that they were saying. And our goal really was to simplify things to an extent. And infection and any other abnormalities are things that we'd be looking for, and knowing when to treat them, which I think Elizabeth will talk more about that too. Just, yeah, inflammation phase versus infection versus all those different things. And then to stage or not to stage. And I said, let's keep it simple. All wounds, regardless of etiology, can be classified as either a partial wound or a full thickness wound. And I like that. Like, have you guys ever used that term, Jen and anybody?
Mhm.
I really like it. And that is what they stressed in this class, like over and over. Every single wound that you ever see basically is either a partial or a full thickness. And partial thickness is confined to superficial skin layers. Damage does not permeate below the dermis and may be limited to the epidermal layers only. Full thickness tissue damage involves total loss of the epidermis and dermis extending into the subcutaneous tissue and possible into the muscle and bone. So every wound, be it a pressure injury, a burn, anything, could be, you know, simply a partial or full thickness wound. And then it talks about staging pressure injuries. And again, there's more information on the sheets with this, but we're all aware of the stage 1, 2, 3, 4s, unstageable, suspected deep tissue injury. And then talking about venous stasis ulcers, dermatitis, venous arteriodiabetic. This was Elizabeth's entry because she says, darn it, people don't know enough about that. So she'll educate us on that. Pressure wounds, just an example. Like I said, I think we're all aware of these, but just a little refresher on the classifications of or the staging of wounds. And pressure injuries occurs due to pressure. Localized damage of the skin, underlying soft tissue, usually over a bony prominence or related to a medical device or some other device. Contributing factors, extrinsic and intrinsic, of course, lots of factors go into that. There's lots of ways to classify wounds, diabetic ulcers, skin tears. I mean, it is an endless list of classification. And I think our goal is, again, should be to simplify. And there are some tools that are pretty simple that hopefully we can get out and all agree on, and we can use those. And it talks about burns here. And here again is that for hospice purposes, simplify. Partial thickness, heals by epithelialization, all the things. Full thickness wounds, talks about the healing process there. And I think that that is a very simple way to do things. And I'm kind of rushing through this, you guys, because we only have an hour and there's like so much information, and Elizabeth has a lot of information. So if there's any questions or anything, feel free to write them down, reach out, and we can go over those too. So communicate as you, I don't know, does anybody here think communication is excellent between all of us? Maybe, maybe not. But like, so let's communicate. And Tammy, I'm so glad you're here too, because man, you get down in the nitty gritty of our patients. So this is like so helpful. I'm so glad you're here.
Me too.
But let's communicate. Yeah, patient notification, or we were talking about, this is what I didn't get to take out because I talked to Betsy about this yesterday, but we're just kind of, Elizabeth and I were throwing around ideas of where to communicate, but I think there's going to be some different plans. You know, but making sure everybody knows the location, the date of last change, products used, dressing layers, what did you use, and then our, of course, our full assessment in our integumentary section. Yeah, my goal is that we can pull together and agree, if we at Volunteer Hospice are managing a wound, that we have a good way to communicate that to each other, and a way to say, these are the products I used. And so you're not down there in the supply room, like throwing boxes around going, what in the heck am I doing? And then you just head out with like a doer. That's what I do.
Yeah.
So what time is it? Yeah. So again, kind of rush through that, but I want to give Elizabeth time because she's the expert here. Talking about conclusion, again, remembering palliative ambition. If our patients are literally at the end of life and have months to live, it would be so excellent if we could manage the wounds. And so often these wound dressings that we have these days and in general are meant to stay on anywhere from 3 up to 10 days if we choose it properly, based on drainage and change and all those things. So avoiding that referral to home health and that 3-week wait to get them on board, and the use of, you know, Medicare, Medicaid, all the things, if we can manage their wounds, wouldn't that be fabulous? And then they don't have multiple people coming into their home. And so again, establishing goals with our patients, and what is their goal? Is their goal to heal that wound? Is it just to maintain it? Is it just comfort, odor control? What are the goals of the wound? I think that's really important. And again, assess, plan, implement, follow up, understanding that there is no cookie cutter mold, no dressing, nothing that's going to fit every single patient. I know that it would be great to have a little bag of like, these are the things you use for a dressing, but every dressing is different. And I did send you guys a little form on choosing a dressing that was helpful for me. And I have more information to send you on that too. And follow-up and communication. So again, falling back to my goal is that we can just find a solid way that we can communicate the plan of care of that wound. That includes communicating it with the family, communicating it with each other, communicating it with the patient, of course, but involving them in that communication process. That's it.
Wow.
Good job.
So I think that it would be awesome. I appreciate your attention to time, Haley, and you just sped through that. But let's take a few minutes for questions on what Haley, or comments, ideas.
I think you did a good job. It's a little overwhelming.
It is.
But the thing, I think the conclusion kind of simplifies it again and pulls it back together, so I don't feel quite as overwhelmed again. And one of my concerns is, you know, measuring. I'm used to measuring. I'm in wounds in the hospital and having the supplies to do that. We don't. Is there some way we can get I know how important measurement is, but we don't have the supplies to measure.
You know, I'm glad you said that, because I feel like what supplies should we make sure everyone has access to easily is part of good wound care. And
So on that note,
what do you need and what's reasonable? Maybe we should supply something.
Elizabeth and I were talking about that, and believe it or not, over in PA one time, I found a whole ginormous bag of disposable measuring tapes.
Wow.
They're just like the paper measuring tapes, and there was a
Yeah.
whole bunch of them. So Elizabeth and I were discussing that a bit and getting together and like pulling out some of those basic supplies that you would use. And so that will be addressed for measurement and the concept too, like I said, head to toe, side to side every time. And yeah, if we can supply those, that is part of our plan in this process.
Well, good.
Thank
And
you.
you know, on the long Q-tips that we get, if they're in a package, along the edge of that is a little ruler. Now it only go. That's what I usually use.
Ruler.
I keep one in my bag with me at all times. But if you have like a massive wound, I think it maxes out at like 6 centimeters, 8 centimeters. So if you have something really, really big, like
we have the paper tape, the folded paper tape. Those
are better. Yeah.
Yeah, we have those, and there's quite a few of them. So Elizabeth and I will find those and get them out to everybody, so everybody has a supply instead of sitting in a freaking box in a bag tucked in the back of the corner.
Yeah. I like your idea of using those Q-tips though too, because a Q-tip is probably a good tool for poking around.
Yes.
You know, just like really assessing if there's undermining.
Sure. You stick it in a hole and use your pen or your felt pen and mark where the top is, and then you take it out and measure it on your paper tape.
For depth. Yeah.
Like stick it in a hole. And Elizabeth is going to go over measuring and stuff somewhat, right, Elizabeth, in your section.
Not very much, but we'll do it. We'll do it next. We have 2 of these one more coming up after this lesson. And that's where.
Yeah, and Elizabeth has a lot of photos. Yeah, Elizabeth has a lot of photos of wounds, which she's going to show you right now. And for me doing this class, I was so overwhelmed and like, what in the hell am I doing in this class? I literally wanted to stop it in the beginning because I didn't even have a clue what they were talking about until they started showing the pictures, right? They started showing pictures of wounds and describing them, and it started to make sense. So that's Elizabeth's job.
All right.
Okay, let me show you some pictures. I'm going to share screen and slideshow. I'm always trying to do stuff with my glasses off. Share. Okay, so are you seeing anything yet?
Yep.
Yes.
Mhm.
Okay. All right, so at the advice of my manager, I put in a blank screen to begin with. You know,
But you're giving it away. Elizabeth, we can see the whole slideshow. You got to get into like the right viewing. Like click on the word slideshow, yeah.
I have from the beginning and there.
Give it a minute. It takes a second to load.
Yeah.
There we go. Okay, the question is, you walk into and see this kind of a situation, and you ask yourself, where in the heck do I start? And I don't mean to horrify you with this picture. This is, as Betsy said this morning, she says, is that a Kennedy type of wound? And yes, it is. This is a very complicated and very severe one that we quite frequently find in places where there's immobility and the patient's whole body systems are shutting down. I don't understand what my is this moving for you?
It's not moving.
There we go.
Yeah,
Okay.
there you go.
So
We want to get it bigger though, Elizabeth. Maybe try to get it a little like full screen or something. Is everybody else seeing it as kind of small for the print?
Yeah.
This is the type.
That's going to shrink it probably.
I'm going to leave this way. Let me just go on because this is all very small handwriting on purpose. It's to tell you that when you come into a situation like that and you say to yourself, what in the heck am I going to do? You sometimes your gathering of your senses is very difficult. There's chaotic thinking and you want to go straight to what the diagnosis is. And I want you to know there's a big gap between what you go in and see and the diagnosis, because many times you may not ever know what the diagnosis or the cause of that wound is. So let's talk about a simpler way of approaching a wound than trying to diagnose what's wrong and treat it based on the diagnosis, okay? The phases of wound healing she went through, inflammatory, proliferative, and remodeling, you should get that into your mind and into your hearts because it answers the question, is this wound healing or not? What does this wound need at this stage? In the inflammatory stage, what kind of dressing do I put on it? In the proliferative stage, how do I handle that wound and keep it going? And after remodeling, is there something I need to do to protect it? This gal came into me years ago, a tattooist. She was debriding her own wound, by the way. And I did what I saw and what I diagnosed it initially as, look how large her leg is. I thought maybe, well, she had hurt herself during a part of the tattooing, because I know it's a long process. And so I thought she was, it was a simple wound that I could handle. It went
Elizabeth,
on.
you need to advance your slide. Sorry, we're not seeing that wound.
Oh gosh.
It's the leg wound, right?
Yes, it is.
There you go. Now we see it. Sorry,
Okay.
go ahead.
Okay. So what I want to tell you is it wasn't important at that point what caused it. However, because I never figured out what was wrong. I sent her on, and that will be maybe a time that we'll come to, is where we send it on to someone else. The most important thing is, I don't understand why this is not advancing, but are you seeing, what are you seeing right now? Are you seeing that big wound and it says keep it
Yeah,
easy?
the tattoo.
Okay, I'm just going to keep using that one. Not my own. So the determining the treatment is, what does a wound tell us it needs by looking at it? And I want you to keep it easy. And I'm going to show you an easy way to look at that wound and decide what it needs at that time. You start with what you see. You look at the wound appearance, the wound bed appearance, that's this, the edge appearance, and the peri wound. And I always start from the center out. I start with the wound bed itself, then I go to the edges, and then I look at the peripheral wound, okay? Later on, I might talk about what caused it, okay? But right now, we're not working on that. So you start with what you see, and what the wound bed itself should look like this. If it's full thickness, it should be moist, it should be somewhat concave, it should have fine granular mounds. Some people call it cobblestone, other people call it a fine grainy appearance. It should be beefy red, and it should be firm. And the way you can test if it's firm, I used to use a forceps all the time when I was doing wounds. You can use your Q-tip, kind of push on it and see if it's nice and firm. And any drainage that's coming out of that tissue should be either serous, which is a clear kind of a yellowish color. You know what these look like. I'm preaching to the choir right now, as my mom used to say. Or serosanguinous, because the granulation tissue is very fragile, so it may bleed a little bit and mix with the serum, and so you get this little pinkish drainage or exudate. But there's no problem with that. And also there should be no odor or any unusual odors to the serous fluid. So what do you see? The appropriate dressing is based on what you see. So that means that every time you take that dressing off, you're reassessing in exactly the way I'm teaching you right now. You look at the wound and you say, it's pretty dry today. I need to make that dressing a little moister. Or, oh my gosh, the edges are all macerated. Let's see what we can do to kind of dry this up a little bit so they don't break down. So what you want to do is remember that that granulation tissue is a very, do you see my cursor moving around on that?
Mhm.
Okay. Is that this is a very fragile, microscopic revascularization. And each of those little mounds represents a bundle of these microvascular capillaries, okay? And those little capillaries are bringing tons and tons of nutrients into the area in order to build a very nice matrix. And the matrix is made of proteins and all different kinds of products that the body brings up to it. And so when you see serous fluid coming out of a wound, that is good stuff. That's gold standard. That is what is the body has the possibility of using that to build this matrix to fill in the defect, if it's a pretty deep wound, to fill it in and bring it up to the surface. And at the surface, then the epithelium is triggered to come in and cover it up. So this granulation tissue is critical. And if you notice this guy, he has a nice beefy red looking texture. It's moist looking. It's the granules are very distinct. You can see them, but you can also see that there's some undermining going on here.
Elizabeth, I'm curious, what words would you describe those edges in your documentation?
Undermined. They are not adhering, they're undermined. And they also are not, there's no, you can see no epithelial migration, but we'll talk about that in a minute. I'll show you them, okay? All right, so in fact, here's one right here. If I'm looking at this, and here's my little checklist on this thing. Yes, it's beefy red, but I'm noticing that just on first glance, you notice it's kind of irregular looking, and it might even be mushy looking if you touched it. I'll tell you something about that in a minute. The edges are slanted and adhering. Do you notice how it kind of sweeps down? I'll talk about the edges more in a few minutes, but that's a nice healthy edge. The peri-wound skin, it looks very normal. And I know when I took the dressing off, I knew that there was autolytic debridement going on. Autolytic just means auto meaning self, lytic meaning liquefying. The body itself is sending enzymes up to liquefy bacterial cells, any necrotic tissue that's in there. All of that is being liquefied. And once it's liquefied, you see it in the dressing as kind of a yellow color, or if it's pink with a little blood in it, it might be a pinkish and yellowish color. And a lot of times it's thick. That is not infection. That's not what we call pus, infected pus. That is just debris that was on the wound that the body is naturally liquefying and trying to get rid of so that it can keep on doing its job. So what you're seeing in this is what I call gelatinous necrosis. And it's kind of like when I already peeled some of that off already. So that's why this looks so bumpy and irregular. It would have looked a little more symmetrical across this whole wound bed had I not, if I'd taken the picture before I debrided it. But my debridement a lot of times was just a pair of forceps, and I would just pick this stuff off, and it's like Jello, a very firm Jello, like the ones you used to give to your kids to hold in their hands and play with, you know, and you could just pick it out of the wound, and that's why this looks so sloppy.
Elizabeth, you and I had talked about debridement, and I did look it up, and in Washington State, RNs can debride, but you have to be like certified to do it, like to actually debride a wound, you have to be certified to do it. But I did learn with a wound like that too, what you're saying is clean it, use normal saline and gauze and clean the heck out of it, and you'd be surprised at what comes off, and then you can really see the wound bed underneath.
Yeah, and I question what they're talking about in that regulation. They may be meaning with a scalpel where you're actually cutting into viable tissue.
Correct.
So we need to talk about that more. You may be able to take a pair of forceps and pull that crap off of there.
Unless
All
they're
right.
on blood thinners and then they bleed out.
There you go, Haley, good girl. All right, so this
Just a thought.
picture, you tell me, does this look like a healing wound?
Parts
Well,
of
it does
it.
have granulation tissue.
Yeah.
The edges don't look great.
Good
Some of
job.
them look okay,
Yeah.
like
The
like
top
parts
looks
of it look
okay.
like they're healing and parts of it don't.
Yeah.
Is that a thing?
That's a
Yeah.
thing. Okay, so you're seeing a beefy red, so you're thinking that that's granulation tissue. But there isn't any kind of a cobblestone granular type of appearance to that. It's hard in the picture to see it, but it isn't. It's kind of a slick surface. The peri-wound skin looks pretty good around there, maybe a little bit pink, but that's just from inflammation from, it's working on it. There was minimal, this was a fresh acute wound. Guy had just peeled his skin off. And so the edges, you're right, are just irregular looking. That's not normal. They look torn. They're lifted over here. This is just a smooth subcutaneous tissue is really what it is. This is a full thickness right here. This is partial thickness, okay? Now look at this.
Ew. You
Yeah.
say it with such excitement.
Yeah, well, what does this tell you? Well, it tells you that this person is in a lot of trouble. And so are you, because there's a lot of work to be done on this. But if you were to go at and look at this piece by piece, instead of looking at the whole and going, if you were to look at this, you would see here's some nice beefy granulation tissue. You can see that I can see right here, it's autolytically debriding some of that necrotic tissue away. Can you see the little thin pink line? That's where it's autolytically debriding away some of the necrotic tissue. Look at this little tear here. This person's not, this is insult upon insult, this person. Here's a nice clean wound bed. It's beefy, red, fine granular. You can see all the little fine, this is easy to diagnose. Has some underlying structure showing. This one's been prepared for a skin graft. And, you know, they've left it, you know, they put probably about a moist dressing on it for a while to see if they can get some granulation tissue to grow over those pieces there.
So how would you describe that, Elizabeth? What would
Which
that wound
one?
be? You said it was
This one?
easy. Yeah.
Yeah, I would say that this is a beefy, very good, healthy granulation tissue beginning to show some covering of the structures beneath it. It has sharp edges that have been, you can tell they've been debrided away, so there's no epithelial activity yet. And that would be very hard for that to do. So that's why I think it's ready for a graft.
Is that a tendon?
Yeah. Yep. You can see some fibrous sheaths here.
Yeah.
Okay. So we're looking at a wound bed now that is kind of granular looking. It looks like it's got granulation tissue and it's got some very firmly adhering necrotic debris on it. Okay. But what's going on here? Well, it's not beefy red, and it could be that this person is a diabetic. They don't have really good circulation in there, or this granulation tissue. In other words, we don't really know what's going on, but we know that it's not a normal looking. It would tell me that there's slight wound clearance going on, but it's kind of indolent. It is got maybe a lot of bioburden, but that's only about 25%. So here's another, and I believe that might be the same heel with a very fluffy looking hypergranulation looking tissue. It's surrounded by this callus. This is, by the way, this is keratotic tissue. This is the top layer of your skin migrating into that area to create a callus around it, just like you get a callus when you walk around with shoes that don't fit very well. You know, the body will move those keratin cells to a heavily trafficked area, so to speak. And you find those mostly on the hands or on the palms of the hands or the feet. So hypergranulation tissue, where this is fluffing out like this, it's also known as overgranulation, or on horses and things, they call it proud flesh. And it's identified because it's yes, it's red, but and moist, but it's very friable. If you touch that, it'll break off. Those little mounds will come off in little pieces sometimes. And it's healthy. It's healthy in that it's not infected, and it's not a problem as far as the granulation tissue is concerned, but the epithelium cannot go over something like that. Epithelium usually goes downhill, not up on these mounds, okay? And so I noticed this right here, and that, as soon as you debride it that way, the epithelium can start growing again, but you need to get that granulation down. So I just take the dressing and put it really firmly against. I build it up so that it's a nice fat dressing, and I tape it down hard, and the granulation tissue, this top part, will die off. The next time I take the dressing off, I'll see more necrotic tissue, and if I didn't know what was going on, I'd panic. But it's really just pushing back that granulation tissue. You can use silver nitrate to burn it back. I can actually take a scalpel and cut it off so that it will, the epithelium will have a chance to grow over it. Are you following me on that?
What causes that?
Sometimes it's a high colonization in the over the wound. Sometimes it's just somebody's in their genes. They just grow this really hypergranulation, very exuberant granulation, if you want to call it that. Okay, so looking at it, you may see dusky or red, dusky red tissue, or tissue that bleeds easily. This is the only picture I could find to show you the dusky appearance, but this wound bed could look dusky like that too. And again, that could be a number of factors. Could have to do with bacterial count. It could also have to do with poor circulation. This probably was an arterial wound right here.
So Elizabeth, when you say that about that top wound, do you mean, so it would be to like simplify, if we cleaned it really good and then like you said, you cover it, you make a big fat dressing, cover it hard and let that tissue die off, where you're using kind of the body's own process of like autolytic debridement to come in, kill that, we take it off and then we start fresh. Is that fair?
Yep, yep. And it
So
will,
that's one thing that I learned that was new to me, you guys too, is just how strong the body is with like its own autolytic debridement properties. And I think that's what you mean,
Absolutely.
is
Yep.
letting the body do its work instead of feeling like, oh my God, we got to put a ton of product on this. We don't need to.
there are some expensive products and sometime may need to talk about some
Yeah.
topical enzymes or, so forth, but the body does a wonderful job. So other terms that you can use when you're describing the wound bed, the granulation tissue can be described as boggy, friable, shiny and smooth, hypergranular. The eschar that's on top of it, it can have different, it's all the same thing. It's still dead tissue, dead skin, but it can be hard or wet, soft, thick, thin, brown, tan. You just describe what you're seeing. This is, again, gelatinous necrosis right here. And this is more of a boggy looking thing. If you took your Q-tip and pushed into it, you'd find that it's kind of wet on the top. You can wipe off a lot of that wetness and the granulation tissue wouldn't feel firm and healthy. And this is just a serous crust around the edges here. So crusting or scabbing, as I showed here, and overall, you can describe the wound as indolent or senescent because it's just worn out. In fact, actually with chronic wounds, the cells themselves change their chemistry and they become what is described as senescent or as indolent. And you don't have to make that diagnosis, you guys. I'm just giving you a broader view of what you look at in an organized way. Okay, so there, drainage. As I said before, it can be serous, sanguinous, serosanguinous. It can be purulent, and purulent doesn't mean it's infected. Purulent is this thick with lots of cells in it, like liquefied dead cells, skin cells, or liquefied bacteria, or whatever else is in that wound that the body has autolytically been debriding. It becomes thick when the drainage, the exudate comes out. It's only when you notice odd things like it's becoming a very strong odor. And down here, I'm showing you a picture of what Pseudomonas, one of the more typical and more obvious infections. And the exudate is kind of a green color, and if you smell it, it's extremely sweet. I forever have been wanted to, like my brother used to be able to describe wines by, he had a little sample kit. And he would smell, this one is this and this one is that, I always wished I had something for exudate, so I knew what the smell. This one's staph. This one is enterococcus.
That sounds like a party.
These little petri dishes.
Yeah,
now
they used to do that in clinic, sniffing urine. That was not uncommon at all, wasn't it?
Microbiology, they made you do it. Yeah. Okay, so I want you to understand there's a difference between a scab and eschar. Eschar is actual dead tissue. This is found in full thickness wounds. It's not interchangeable with scab. A scab is actually a crust that's formed by coagulation of blood or exudate over these shallow wounds, or for superficial or partial thickness wounds. Now, in your child, you probably want to leave it on there and not worry about it, but on a patient who is compromised nutritionally or immune wise or whatever, you want to keep a watch around the edges, because the edges begin to lift up as the body tries to heal underneath that scab. And as it tries to heal, it lifts the edges of the scab, and it's moist there, and bacteria can get in there, and you can have a pretty serious infection underneath a scab, which is supposed to be supposedly a protection. Eventually the scab will pop off if it's healing normally and naturally. It's fine, but this is not the same as eschar. So we're going to go to the edges now, and you start with what you see. on the edges, they should be adhering. It should be slanted, kind of a shiny, I don't want to say, I shouldn't have said silvery because silvery is more with remodeling. But anyway, it's adhering and slanted, and it is kind of shiny looking. There's wound contraction apparent, and a lot of times you don't see the skin tugging and pulling in, although sometimes I've seen it. You see mostly the contraction is evident because the wound is a little bit smaller. The measurements are a little bit smaller. And you can't see more epithelial tissue, but you do see that the wound is smaller. And that's because the cells around the edge begin to contract. They pull themselves together and get smaller to pull the edges in closer to each other. So there's less space, surface area that the epithelial cells have to go to cover it up. You follow what I'm saying? The little cells contract in order to make the wound smaller, plus epithelialization is going on. So this is a picture of a slanted adhering epithelium. It's yeah, there's a little maceration, big deal. Don't worry so much about maceration. We'll talk about that later on. But if you have say you put it, and this, by the way, was covered with a tegaderm. If your tegaderm is on and it's leaking a little bit around where the edges are and it macerates a little bit, take that tegaderm off on your next dressing change and you'll find that this edge will dry up very quickly. It isn't going to destroy your wound, okay?
Elizabeth,
Yeah.
what is the significance of slanting? The
Oh.
edges being slanted?
Very good question. Yeah. The slanting means that the what epithelial cells do is they kind of like if you look at think of a little pod, and one end of that pod kind of points and stretches, and the other end, the opposite end of it kind of contracts in. They move that way. That's how the epithelial cells move across a wound. And they have to move in moisture. If you dry out a wound, they've done studies where it takes 2 hours after drying out a wound for the epithelial cells to start migrating again. So what happens is they hook onto each other, they hold onto each other, and they do this kind of movement across the surface of the granulation tissue. And they, so that's only one layer thick. And so where you see it thin here, that's only one cell thick. And up back from it is maybe 2 or 3 layers thick of epithelial cells, okay? So the slanting just means that it's building up here while this is marching forward. Did that explain that, Anne? Okay.
So in general, is it like a smooth, gradual beach is healthier
Yes.
than like a cliff kind of?
Exactly. Yep. A lot of people describe it like that.
Okay, so I just want to say that in 8 minutes, the CareXM people are going to be on a Teams meeting. In your email, there is a link to that meeting. And if we can just be ready, you know, in 7 minutes or so.
Will it
to
automatically
over.
click over? Will you just automatically click over?
No, you're going to have to go to your email. And then you will see, I just sent everybody on Nurse Report an email with the Teams link. And I hope that that's smooth.
Okay. Let's see if we can get through this a lot
I
faster.
wish we could just go on and on with this, but yeah, we're going to return to this topic. So we'll get as far as we can. Okay. This is awesome.
Okay, so here's a very fragile epithelium growing over this. I want you to know that epithelium can be very aggressive. In fact, before the granulation tissue gets really in, filling it in, it can already be pouring over the edges. So it's not supposed to do that. So you could call it rolled edges, distinct, irregular, diffuse, defined shape. It can be any way you want, but you'll find after a while that some of the edges are characteristic, like with a venous stasis wound, it's very irregular. With a arterial wound, it's like a punched out wound. It's circular and has sharp edges. I'm gonna skip through some of these here. Peri-wound appearance. The color should be the same as the surrounding skin. The temperature should not be elevated, but it should be warm, you know. Absent swelling or induration. By the way, induration is not supple, like swelling can be kind of soft, whereas induration is hard. You push down on it and it usually makes kind of a bump. And it should be, the skin, the normal skin should be dry and supple. You may, other variations of that might be maceration, erythema, induration. Fluctuant is fluid underneath, like you have a abscess or something underneath and the fluid is kind of sloshing around in there. Edema, increased temperature, exfoliation. These are all terms that you're familiar with and I'm just going to pass on by them. Okay. Let's go down here. This is called, you'll see this very typically on venous stasis patients, even with the skin's intact and there's no wound. You see this lipodermatosclerosis, which is a toughening of the skin and it kind of loses all its moisture and it gives you that upside down champagne bottle look to the leg. Hyperkeratosis is a keratotic tissue that's migrated to that area. And sometimes it's called venous stasis dermatitis. The remodeling looks kind of like this, and you notice that this is still kind of indented. As the remodeling goes on underneath the healed skin, it's very chaotic under there, and the body goes in and totally tears it out again and lays down more smooth, better, firmer tissue that will hold. And as Haley said, it's only 80% of the original tensile strength because it's a lot of collagen in there. Collagen breaks easily.
Why don't you stop, or just like pause on that
Sure.
slide and have like a minute or so for anybody, 3 minutes. Is that all right? Before we switch over, because this is super important and interesting, but we're not going to get it done. So, right? Anybody have something on their mind that they want to say? Question?
I really appreciate the opportunity to learn all this. It's really pretty fascinating.
Yeah, it is.
Yeah.
fascinating.
Yeah.
Well, just remember, we're going to try to we will pull in what types of dressings and what other kinds of treatments we would use. But you needed at least a foundation of understanding of what we're talking about when we get to that.
Yeah. Well, and this has been really good. I think it leaves me feeling like, oh my gosh, what would I do? But if we can at least start talking to each other about real life wounds that we see and just asking a lot of questions and learning about them still. And then when and how do we continue this learning? Staff meetings, we've got LNET coming up, lots of good learning ahead. But
I have a quick question about Eshar, because I always have a hard time with that. The same exact thing that you said, like, this is a scab, this is Eshar. Like, I think of it as being a black, really hard scab. That's what
Yes.
it looks like to me. Is that wrong? Is that right? I
You're
don't
wrong.
know.
You're wrong in that, excuse me, that teacher never says that to a student.
Oh, I can be wrong.
It is actually, it's jerky. How's that? It's like jerky. It is dried tissue that's been so dehydrated, it's totally dead. The scab is nothing but serous fluid coming up and drying out
Okay.
and creating a crust. That's the difference. One is skin, the other one is serous fluid.
so
And you
I
have-
might have used the word necrotic tissue for that big black guy.
Yes,
So
absolutely.
and
It
you're
is.
using necrotic for when it's still yellow sometimes. So that's a term that
Necrotic tissue is a generalized term for any kind of dead tissue. It just means, necrotic means dead, necrosis, right?
yeah. And so is eschar dead? Eschar is a form of
Yes, that's necrotic tissue. Yep,
Okay.
it's dehydrated. necrotic
Yeah, and
tissue.
that was a learning thing for me talking to Elizabeth because she has so much knowledge. She just kept using necrotic tissue versus like eschar, slough, all those things. And I was like,
Yeah.
I kind of like that. Just like necrotic tissue. It's an umbrella term for all dead tissue.
Yeah.
Keep it simple. Yeah.
Yeah.
Black. Yeah. Huh.
Okay, yeah, because I often worry wonder if I'm using, like, Haley, when you were saying, don't use a word if you don't know what it means.
Yeah.
Like that seems so obvious, but sometimes I'll use the word Eshar, and every time I do it, I'm like, am
Is
I
it Escher? Yeah.
right? Yeah,
Yeah, you gotta
Yeah.
know your terms or you sound kind of stupid in front of a physician.
totally.
I do.
And each
Like that.
other.
And and peers. Yeah. So that's why I say what you see, a black area of
Yeah.
tissue, necrotic tissue.
I'm gonna get off of this call. Elizabeth actually opened up the Zoom, so whoever's the last one off the door, this will be recorded for anybody who wants to remember it or watch it again. And that was awesome.
Thank you so much.
See you
Okay.
on Teams. Yeah,
Yeah,
thank
thank
you.
you guys. Appreciate that.
Wow.
Um, Hey, Anne, are you still there?
I am.
Are you able to join this Teams meeting?
No, I don't know yet.
Mine doesn't allow me to join it. It just says,
It says when the meeting starts, we'll let people know you're waiting.
did you go through your emails?
Yeah.
Well, if you get on it, keep it turned loud and I'll just listen, stay on here because mine is not
I
allowing
don't know
me to.
why it's not coming on though. I mean, it said 9:30 and it's 9:31.
Yeah, it's
Speakers
not.
on, cameras on.
Microsoft Team meetings.
I'll try on the iPad, see if that works.
Yeah, I'm on my iPad and it's not working. Oh, maybe now it is.
On the iPad, it won't let me, it just said sign into accounts, but there's nothing there's no camera or it's just blank.
Yeah, and I just did that too, and it says someone will let me in the meeting, but I had to sign in as a guest. So I'm texting Betsy.
You signed in as a guest?
That's what it says, but it's still not letting me in. So I don't know.
Yeah, when you text her, tell her I'll sign in as a guest, but she can add me.